Good morning, student. This is the second lecture of epidemiology course for medicine second year. Good. Last time we have seen association and we have seen how can we calculate relative risk, odd risk, and more calculations about. So today we are going to see analysis of cause-effect relationship and screening. Cause-effect relationship, when we say, last time we have discussed about with the relationship between exposed and unexposed, with diseased and non-diseased. We have calculated and we have got some figures. But is it these figures have really they have a relationship? What is their effect is that they have negative effect, positive effect, and what affects this relationship again. So we will see under this topic what we have said, analysis of cause effect relationship. Good. What is analysis of cause effect relationship? That is the existence of statistical association does not in itself constitute of a proof of causation. The observed association could be a real or false. We are going to identify this. So based on what? For example, purpose of what's the purpose of evaluation of evidence? This is to determine if what is observed is a reflection of the truth. Sometimes maybe it is reflects the truth, sometimes maybe false. For example, what's observed? Prevalency is there, incidence, relative risk, odd risk. Are they true? Are there alternative explanation for this one? So to identify this, we will see cause-effect relationship. Under this, one is validity of epidemiological studies. It refers to the degree of closeness between measured value and the true value of what is being measured. There are two types of validity: internal validity for particular group of people and external validity for general population. So internal validity, when we say it is a degree to which the result of the study are correct for a particular group of people in studies. External or generalization, as you observe from the term, external validity or generalizability, the extent to which the result of the study apply to the general population, not to the specific group. To show the valid statistical association, we should assess for major three things. What are these? Bias, role of chance, and the confounding. What is bias? Bias is whether systematic error has been introduced into the study or no. Role of chance, how likely is what we found as a true or real finding. Confounding, whether the externals or external factor is related to both disease and exposure. Good. So let's see what is role of chance. Role of chance, when we say it infers, involves in making generalization of the result in a sample to a large group reference population. When an inference is made from a sample, it may be inaccurate because of role of chance. One of the major determinants of the chance affects the finding in any particular study is sample size. The smaller sample size from which our inference is made, the more variability there will be in the estimates, and the less likely the finding will reflect the experience of the total population. Role of bias. Bias is any systematic error in the design, conduct, or analysis of the study that result in distorted estimate of what the study is attempting to measure. The possibility of bias exists in assessment of association between exposure and disease. There are two types of major bias in the study. One is selection bias, the other is information bias. Selection bias means the bias or the error that the data collector or investigator will select by their interests. Maybe they don't want to go too far away, like maybe they don't want to go to rural area due to maybe transportation like this. Then maybe even in the town they will select few qabalis. So this is what we call it selection bias. The other is information bias or observation bias. Information bias is mostly when you ask the question. When we ask the question, those who are answering the question, maybe they will not tell us the correct information. Maybe recalling bias, they may forget about maybe what happened before 2 days, maybe what happened before a month. They will not remember. So this is what we call it information bias. So simply we can classify role of bias into two: selection bias and information bias. Selection bias is introduced when selection of subjects depend on the interest of data collector or investigator, as we have said. It can be introduced when the kind of study subject is gathered does not represent the case originated in the population. Bias is also introduced if the selection of the study subjects follows different criteria. How can we minimize selection bias? One, population-based study is preferred. One. Second, put proper selection criteria, inclusion criteria and exclusion criteria. Good. The other is information bias. Information bias means simply error observed in measurement or information obtained in the study could be error due to difference in participants, biology, or error due to observers. Example, investigators bias or interviewer bias or observer bias. These form of bias occur when investigators collect information differently. The other is response bias. Response bias occur as a result of difficulty to recall or remember prior to exposure. Ways of minimizing information bias? It is blinding. We are going to classify this as single blinding, double blinding, and triple blinding. Single blinding means the study subjects do not know to which group they are assigned. The study subject, they don't know their group, where they are assigned. One. Double blind, when we say neither the study subjects nor the data collector, both of them they don't know. It can be study subject and data collector. Triple blinding, when we say it can be study subject, data collector, and also individual who is going to doing the analysis are blind. They don't know. So blinding have greater importance when the outcome is subjectively determined. Role of confounding or confounder. The word came from Latin confounder, meaning to mix up. An observed association be due to mixing of effects between the exposure, the outcome, and the third factor that affect the development of disease. This is referred to as confounding. So the external factor which creates that wrong association is called confounding variable. Approaches to control confounding. One is randomization. This is especially important in interventional studies. It ensures that all potential confounding factors are evenly distributed among the comparison group. Second one is restriction. Individuals who fall within a specific category or categories of the confounders will be included in all studies. This is all about cause-effect analysis. The other is screening. What is screening? What we are going to screen? So simply, the early screening means the early detection of disease and the susceptibility to disease individuals who do not show any signs and symptoms of disease in apparently healthy individuals. Individual is not coming to hospital due to developing signs and symptoms. If the individual develops signs and symptoms and they come to hospital or health center, we call it diagnosing, not screening. But screening means those who do not develop, they don't know whether they are diseased or not. So the presumptive identification of unrecognized disease by application of rapid test or examination. That is what we call it screening. Diseases appropriate for screening. Is that all the diseases that we are going to do? No. First, it should be serious disease. It should be serious. Like nowadays, there is what we call it coronavirus. So it is very serious. It is worldwide. It is a pandemic. So that is very serious. So if you go to screen the people, we call it screening, not diagnosing, because it's very serious. Second one, treatment given before symptom should be more beneficial in terms of reducing morbidity or mortality than that given after they develop. So these are the major two to identify or to do screening. Criteria for establishing screening program. What the condition should be important healthy problem. If it is important healthy problem, we should develop screening program. One, screening should be undertaken only when it has the potential to lead significant in decrease in rate of disability, death, or both. There should be an acceptable treatment for patients with recognized disease. Facilities for diagnosing and treatment should be available, should be economically balanced again. What's the purpose of screening? Aims to reduce morbidity and mortality from disease among persons being screened, to prevent or delay occurrence of disease or improve its prognosis, to prevent transmission of disease. Is that diagnosing and screening is the same? No, it's not the same. Screening means already, as we have said, it is done among individuals who are not suspected of having disease, like HIV, widal test, clinical examination, X-rays, different kinds. But diagnosis means those who develop signs and symptoms, involves confirmation of presence of or absence of disease in some suspected or at risk of the disease. So screening tests can also often be used sometimes as diagnostic test. Validity of screening tests. The ability of screening tests to differentiate accurately those who have the condition from those who do not have. Key measures: sensitivity and specificity. These are two measures in screening. So validity assumes that there is a gold standard to which a test can be compared. So let's see these two. What's the difference between them? Sensitivity is simply about disease. Specificity is about non-diseased. So sensitivity, when we say ability of a test to correctly identify those who have a disease. So when we do a test and when the test is positive, it should be true positive, not false positive, true positive. So in these cases, a test with high sensitivity will have a few false negative. There are few false negative. Few false negative means positive. Therefore, it concerns about a disease. Specificity, when we say the ability of a test to correctly identify those who do not have a disease, true negative, who do not have a disease. A test that has high specificity will have what? A few false positive. So this is the main difference between them. Good. To calculate sensitivity and specificity, we are going to develop a 2 by 2 table. You remember when we do what we call it association in measures or measures in epidemiology, when we discuss about odd ratio, relative risk, we have developed 2 by 2 table. The same is true here again. For both, we are going to develop 2 by 2 table. From this, sensitivity means a proportion of individuals who have a disease who test positive. Therefore, tell us how a positive test picks up a disease. That means simply it is about what? It is about, yes, proportion or about the rate. It is about the ratio? No, it is about proportion. Good. So observe here now. From diagnosis area, from the top, disease is there, non-disease is there. Downwards through the diseased, true positive, yes, it is diseased. False negative, false negative. It is what? That means true positive, diseased, total diseased. When we come to non-diseased means false positive. It is to say false positive and a true negative, both of them. From horizontal test result, previously when we discuss about what we call association, when we say exposed, non-exposed, Now we are going to say that table rows positive and negative. Positive, true positive is there, false positive is there. Negative, false negative is there, true negative is there. Now from this table, we are going to calculate sensitivity. So sensitivity means true positive over over total diseased. True positive means diseased. Overall diseased. Don't forget. True positive over all diseased means true positive over true positive plus false negative times 100. It is written by percentage. So this is what we call it sensitive. Don't forget true positive over total diseased. When we come to specificity, specificity simply we have said about test of negative or not diseased. Therefore, simply it is those who have test negative or true negative over total non-diseased. What are total non-diseased means? Total non-diseased means false positive plus true negative. Therefore, true negative over true negative plus false positive times 100%. This means simply, if you remember from previous 2 by 2 table, A, B, C, D. A means true positive, B false positive, C false negative, D true negative. I will ask you like this, don't forget. So what do you mean specificity means? True negative means what? D. D over B plus D. D over, yes, D means true negative. So the true negative over false positive is B, true negative is D, B plus D. But when we come to sensitivity, true positive over total disease, that means A over A plus C. A over A plus C. Then times 100. Don't forget, maybe I will not develop 2 by 2 table. You will develop. So when it is simply written, maybe I can say this amount is positive, this amount is negative. This amount is diseased, this amount of non-diseased. So don't forget to develop and how you develop 2 by 2 table. Good. Predictive value of screening test. Predictive value, when we say, it is the ability of a test to predict the presence or absence of a disease from the test result. So there are two things here: positive predictive value and a negative predictive value. Positive predictive value test, when we say, it is a probability of the presence of disease among those tested positive for the screening. Among test positive, do you think all who test positive is become disease? No. Among these test positive, what is the amount those who have really disease? That is what we call it positive predictive value. So positive predictive value is equal to true positive over true positive plus false positive, then times 100. Negative predictive value of screening means is a probability of not having disease when the test result is negative. That means specificity. So from the total true negative, do you think all the true negative have no disease? No, sometimes they may have disease. So to identify this, we are going to do negative predictive value, which is true negative over true positive plus false positive times 100. The ability to predict the presence of or absence of a disease from test result depend on prevalence disease in population. That is sensitivity and specificity of the test. High prevalence of the disease is the higher. High prevalence disease means the higher positive predictive value. Low means negative predictive value. So don't forget this. How can you evaluate? Evaluation of a screening of program. Evaluation considers two issues. One, program is feasible or is it feasibility, acceptability, and the cost effectiveness. When we say acceptability means it should be acceptable to the community. It should not be contraindicated with the cultural of there. It should be considered. When you do this screening, yes, all the criteria should be set. Cost effective again, maybe if it is not balanced. If you yourself you can cover all things, no problem, but sometimes you cannot cover all things. That's why we say it is a little bit difficult if the cost is high. The other is program effectiveness, reduction of morbidity, mortality, and disability. It should be effective. You should reduce morbidity, mortality, as well as disability again. So these are the two evaluation criteria. So you should identify these all first before doing a screening. Good. Assignment already. I have given you your assignment, which said for instead of that of what we call it for mid exam, do your assignment. So this is all about second semester. If you have question, write me through my WhatsApp. This is all about. So for your final exam, I will discuss uh, with your university managements. Then after, I will send you the message from which I'm going to prepare final exam. Maybe I will not prepare from all chapters. So I will tell you that till that have information. See you.